So the topic of my talk, for those who are not residing in Hong Kong, this is Victoria Harbour. You can see Victoria Harbour from here as well, from the opposite direction. So this is my hospital, this is my building. The department is housed within this new building. Well, not new, it's been built for 21 years or 22 years already. So it's from a collection of up to almost 9,000 patients collected by Hong Kong Cancer Registry, which is the only population-based cancer registry in Hong Kong. We know we are dealing with a lot of patients having ER, PR, or we call it hormone receptor-positive breast cancers. 60% of them actually are having ER, PR positive, HER2 negative, and about 15% actually are having triple-positive disease. Incidentally, about 30% actually had triple-negative disease. There was the data from a cohort of patients collected over about 3 years from Hong Kong Cancer Registry. So we know for patients with advanced or recurrent metastatic cancer, I think the primary goal would be palliation. And we would like to delay the time to disease progression for our patients with a view to maximizing control of symptoms, maintaining quality of life, preventing serious complications, and ultimately, if possible, to try to prolong overall survival. So obviously, chemotherapy is indicated in visceral crisis or patients having life-threatening complications from the breast cancer for various lines of therapy. However, hormone therapy should be the mainstay therapy, which should prevail in different lines of therapy until the point when the patient is having hormone refractory or resistant disease, at which time I think the patient should be channeled back to chemotherapy. So I think it's a concept that we should tease out before we move on into the talk. So it's about the concept of hormone resistance or sensitivity after prior adjuvant therapy. So the current standard of adjuvant therapy would be 5 years of either tamoxifen or aromatase inhibitors or a combination of both. We're talking about 10 years, but still it's not widely accepted. When you have recurrence quite distant away from the completion of the adjuvant hormone therapy, like more than 6 years, I think people are having the consensus that perhaps a patient is having a hormone-sensitive recurrence, which is not the case when the patient is having recurrence within the first 5 years or 6 years of adjuvant therapy. And indeed, when you have recurrence within the first 2 years of adjuvant therapy or hormone therapy, we will call the patients having primary hormone-resistant disease, whereas those patients having recurrence within the next 4 years, I think they are generally regarded as having recurrence, having the secondary hormone resistance rather than primary. Similarly, in patients having progressive disease during hormone therapy intended for the recurrent or metastatic disease, all those patients actually are having hormone-resistant disease, and patients having progression within the first 6 months of the primary or the metastatic treatment, we are talking about primary hormone resistance. And when patients having progression after 6 months of the metastatic treatment, we're talking about secondary resistance. These concepts are important in interpreting the data that I'm going to present to you soon. So I'm going to share with you a history of one of my patients who presented back in 2011 at the age of 44, premenopausal obviously, and she was treated by the usual mastectomy. It turned out to be a relatively small localized disease, but then she had a lot of lymph nodes, 3 lymph nodes I think, in the axilla, 1.7 centimeter invasive ductal grade 2 extensive LVI, and she had hormone-positive disease, but HER2 negative. Probably a luminal B disease, right, by definition, high proliferative index, some lymph nodes positive. And the tumor boards recommended, adjuvant multi-agent combination chemotherapy, TAC, followed by local regional radiotherapy, and then adjuvant tamoxifen because she was premenopausal at that time. And she will complete 5 years tamoxifen in March this year. But then, before that, she had raised CA 15.3 detected in private, for which a PET-CT scan was then performed. A PET-CT scan showed recurrent supraclavicular lymph node on the ipsilateral side, very small, 4 metastases in the liver, again very small, 2 having size more than between 1 to 2 centimeters and 2 having just less than 1 centimeter liver metastasis. I'm going to show you the liver, the PET-CT scan. So this is supraclavicular lymph node metastasis detected by PET scan, 4 liver metastases with variable size, but in general, very small liver metastasis in general. So again, the cross-sectional anatomy, segment 4, 6, 7, and 8 of the liver, 4 liver metastases, and the supraclavicular lymph node metastasis. So the patient was asymptomatic at that time when she presented with recurrence, We still call the patients having relatively oligometastatic disease with 5 metastases or 5 recurrences. We broke the bad news to her, and we counseled the patients for systemic therapy. Obviously, the liver enzymes were a little bit raised in terms of ALT, slightly raised. And we probably will not be calling that patient having visceral crisis. And the patient at that time was only 49, and therefore we checked the blood for hormone profile, which showed the patient was having postmenopausal status indeed, despite the fact that she was menopause after chemotherapy. But still, according to NCCN guideline, any patient less than 60-year-old while on tamoxifen, I think we need biochemistry confirmation. So the important question would be, what would be the option of treatment for this patient if you do not consider chemotherapy? Obviously, if you can consider chemotherapy, obviously, anthracycline, taxane-based chemotherapy, or single monotherapy using combination hormone therapy. What about targeted therapy in combination with hormone therapy? Well, these are the very important questions that the clinician would like to talk to the patient in counseling her to try to formulate the treatment plan. So when you talk about chemotherapy using single agent versus single hormone monotherapy, I think the ESCO guideline published last year have reviewed the data from the Cochrane database systemic review, published back in 2003, concluding perhaps there's no evidence of improvement in overall survival if you use chemotherapy over just hormone therapy alone, although there might be a suggestion that there might be some improvement in the response rate using chemotherapy as opposed to hormone therapy. So the conclusion of many guidelines, including ABC3 guidelines published in 2016, NCCN guideline, and the ESCO guideline that we just mentioned upon, which I'm not going to show you in the interest of time, all indicated perhaps hormone therapy, single agent, might be the best option for such patients, having patients with recurrence in a hormone-positive metastatic breast cancer without visceral crisis. Indeed, aromatase inhibitor is the key player in monotherapy of metastatic breast cancer, and it has been shown to be outperforming tamoxifen in terms of response rate and clinical benefit rate, with about 10% superiority over that achieved by tamoxifen. And there was about a 4-month PFS gain if you used AI as opposed to tamoxifen. So apart from using AI to try to minimize the level of estrogen in the patient's circulation, and the use of SERM, or selective estrogen receptor modulator, to compete with the estrogen for the estrogen receptor, I think SERD, selective estrogen receptor downregulator, like fulvestrant, is also a very important key player. So this is the Falcon design, the Falcon study, 450 patients, a large cohort of patients, all chemo or radiotherapy, they are hormone-naive patients. They can receive chemotherapy up to 1 line, but all of them actually should have not received any prior androgen or endocrine therapy, including adjuvant therapy. So they were randomized into either fulvestrant, a single agent IM high dose, or anastrozole, and that was presented back last year in ESMO. Interestingly, those without visceral disease would benefit from fulvestrant, a single agent, over just anastrozole alone, whereas those with visceral disease will not be benefiting from this single hormone therapy. And there was a gain of about 9 months in terms of median PFS. So the next question is, what about combination hormone therapy? Well, it will be a very good proof of concept if we can show using aromatase inhibitors to try to reduce the level of estrogen on one hand, and at the same time try to use SERD to try to modulate or reduce the level of estrogen receptor in the tumors by showing a synergistic or at least an additive effect by combining these two. So the SWOG study, SO226, was conducted targeting relatively hormone-naive patients or hormone-sensitive patients, randomizing them to either anastrozole alone, single agent, versus anastrozole together with fulvestrant, using a relatively low dose of fulvestrant, 250 milligram only, but not 500, which is now the current standard. So both the overall survival and the progression-free survival were improved, but only to a very modest extent, 1.5-month gain for median PFS and just 6 months gain for overall survival. And interestingly, at the same time, published in another paper, was the FACT trial showing completely negative results with very much similar design. So how could we account for the discordant results? Obviously, it lies in the fact that patients in the positive trial, the SWOG trial, actually had a larger proportion of patients who have never been exposed to any anti-estrogen as opposed to the FACT trial. highlighting the important thing that perhaps fulvestrant is most beneficial if it's used early, before the use of any estrogen. The other bring home message about these two trials is the so-called early dip in the PFS curve, highlighting the point that hormone will take time to act. So during the first couple of weeks, perhaps there might be suggestion of progressive disease, despite the use of very strong combination of hormone. So the combination hormone is not going to redeem the early dip, which is important. It's like, say now a patient with a marginal liver function, you might be expecting some progressive deterioration of liver function, despite the fact that you have added on the state-of-the-art combination hormone therapy. So this is something we have to bear in mind as well in the management of our patients. But nevertheless, in patients with relatively hormone-naive status, I think general guideline recommendation would be still combination and estradiol together with fulvestrant being one of the viable options to be considered for such patients. So we know there are a lot of crosstalks, right, between the estrogen receptor pathway as well as the other pathways dependent on the estrogen, as well as CK, we got cyclin D kinase, cell cycle signaling pathway, and maybe the PI3K, ATK, and mTOR pathway. So opening up a lot of avenues to try to target all these pathways to try to slow down the tumor growth. So we now come to the picks of our choices, right? What about combination hormone therapy with targeted therapy, for example, mTOR inhibitor? So Horizon trial is the first trial using a combination oral TKI, oral TO, mTOR inhibitor in terms of oral temsivorimus together with letrozole in postmenopausal women, using it as a first-line therapy in more than 1,000 patients. Again, relatively hormone-naive patient and hormone-sensitive recurrences. Unfortunately, the study was negative, perhaps highlighting the point that this pathway, the mTOR pathway, might not be accentuated in hormone-sensitive disease. However, just recently, the Bolero-4, which is a single-arm phase 2 trial, combined everolimus together with letrozole, and again, as first-line therapy in patients without any prior exposure to first-line metastatic hormone therapy. They showed very good, relatively good response, right, and good results. Median PFS, 22 months, and overall response rate about 50%. So one half of the patients will experience some response. So the conclusion of that there's a non-randomized single-arm phase 2 trial on only about 200 patients, suggests that perhaps the combination can be considered as a first-line treatment in hormone-sensitive recurrence as well, producing a median PFS of around 22 months. So what about CDK4/6 targeted therapy together with hormone therapy? So it's important to note that the growth of hormone receptor breast cancers is dependent on cyclin D1, which can activate cyclin D kinase 4 and 6, resulting in driving the tumor cells into the cell cycle and leading to proliferation of the tumor cells. And there are 3 inhibitors these days produced by different vendors, and this slide summarizes the milestones of each of these, the development of each of these cyclin D1 inhibitors, cyclin D4 case inhibitors. In interest of time, I'm not going to talk about any of the clinical trials, just to highlight perhaps the point that as we speak, I think this inhibitor is now moving into the adjuvant space, so we are now testing this drug in the adjuvant setting. Again, this slide summarizes the results of 3 randomized phase 3 trial and 1 randomized phase 2 trial on the use of the CDK4/6 inhibitors in the first-line setting. Overall, visceral metastases were found in about 50 to 60% of all those trials, and the newly de novo M1 disease found in about 30 to about 40% of those patients randomized into the trials. Overall response rate in the range of 40 to about 50%, and median PFS achieved was about 2 years, as opposed to about slightly more than 1 year for the control arm using just single agent and aromatase inhibitors alone. So because of all the results of these trials, the ABC3 guideline, ESCO guideline, and NCCN guidelines have all incorporated this combination into the standard therapy option for such patients. So the MONALEESA-2 is a randomized phase 3 trial. Ribociclib is a drug to be dosed on a 3-week on, 1-week off sort of dosing schedule. So 668 patients randomized to the combination of this CDK4/6 inhibitor with letrozole versus just letrozole alone and placebo. 1/3 patients got de novo metastasis, and 2/3 actually had disease recurrence more than 12 months. Median PFS for the experimental arm, more than 2 years versus about 14 months for the control arm, so highlighting the gain of about 10 months in terms of median PFS. Overall survival, no difference. Overall response rate, again, a 14% difference, 42 versus 28 in favor of the combination therapy, and the benefit was shown across all subgroups. Important to note is perhaps adverse events, right? Though up to 60% of those patients can have grade 3 or 4 neutropenia, but significant infection was only found in less than 5%, so highlighting the safety profile of this drug. And the adverse event that's not shared by other drugs in the same class is the possibility of this drug inducing some raised ALT or transaminases in the liver, which is of relevance in patients having liver metastasis leading to already liver dysfunction, as well as those patients having Hep B carrier, which might be having a liver dysfunction because of the hepatitis B. So it's something that we have to consider in prescribing this drug as well. Palbociclib is the drug randomizing palbociclib, the other inhibitor, together with letrozole versus letrozole alone. Again, 600 patients, the same cohort of patients, hormone-sensitive recurrence, visceral metastasis about 1/2, de novo distant metastasis 1/3. Again, benefits of the combination over just single-agent AI. And the response rate difference about 11% this time. And again, 16 or about 2/3 actually got grade 3 or 4 neutropenia, but febrile neutropenia is only found in less than 2%. The last drug that was tested in MONARCH 3 trial. It's abemaciclib. Is again different dosing schedule. It is continuous dosing. It's not a 3 on 1 week off sort of dosing. So it's continuous dosing together with letrozole or anastrozole. Again, showing a benefits for the combination. And the drug is interesting because the patients having significant neutropenia was only about 20% as opposed to about 60% or about 2/3 in the other two drugs. And the other thing is about 10% of these patients will have significant diarrhea requiring loperamide treatment. So our patients was treated with, the patients I just quoted before going into the literature, was treated with the combination of letrozole, palbociclib, on a 4-weekly basis. She need to come back for additional visits mid-cycle to check for the blood counts. She had received pharmacist counseling to ensure compliance. She has completed about 5 cycles. It was an old slide, but by then she had completed 4 cycles, and there was some dose delay as a result of fatigue and maybe some administrative error. So I'm just highlighting the trajectory of the clinical course of this patient against the dates of the different cycles of the combination therapy. So the CEA rose initially and then came down to normal, whereas the CEA 15.3, which is not available in my hospital, but the patient had that checked in the private, climbed continuously despite the use of this combination. So we need a PET CT scan to be the jury. So this is a PET CT scan shown before the treatment and this after, showing resolution of the lymph node metastases, some resolution of many of the liver metastases. So it's segment 3, segment 4, segment 6 all resolved, segment 8 still persistent. And these real-world blood counts of this patient against the different cycles. So you will notice perhaps mid-cycle, day 14, neutropenia was not uncommon, but they never led to dose attenuation or dose reduction. But we do have a few episodes of grade 2 thrombocytopenia in this patient, which has contributed to the dose delay in the first cycle. But most of the time, the dose delay actually were accounted for by the patient's wish or request to try to delay the treatment because she had significant fatigue. So fatigue is important. That has led to delay. Right, so this is not the end of the story. So everything's so far so good. But then when you look at the PET CT scan, there's a suggestion there might be a new liver metastasis found at the same time, segment 3, which was not reported before. So what shall we do? It's an important question. Obviously, we can switch, right? Switch therapy, we can stay on the original therapy, we can stay put. There are a number of suggestions. Apart from just chemotherapy, I think there are a number of other optional hormone combination strategies that we can consider, like, changing the hormone part by replacing the AI with tamoxifen or non-steroidal AI, fulvestrant, or we can change the targeted part by switching to everolimus, even PI3K inhibitor, and so on and so forth. So all these approaches actually are evidence-based, which I'm going to show you very soon. So these are the approaches that we have been using for first line, and then is available also in second line therapy. So mTOR inhibitors is the one that has been used so successfully. That was published many, many years ago. So TAMRAD actually was the first trial using combination of tamoxifen together with everolimus in patients with AI failures. And indeed, the overall survival, as well as the PFS, was shown to be importantly benefiting from the combination therapy as opposed to just tamoxifen alone. But if you look at the TT, time to progression curves, you will see those patients having less AI-resistant disease, as defined by the so-called secondary hormone or AI resistance, benefit the most, and those having really resistant disease for primary resistant disease actually are not benefiting from the combination. So Bolero-2, the oncologists will be very aware of this one. Bolero-2 everolimus together with non-steroidal AI treated for the group of patients having hormone-resistant disease as defined before. So having progression during or within 12 months of the adjuvant non-steroidal AI, or having progression during the AI or hormone therapy for the metastatic disease. So almost 700 patients. Benefits of the combination was shown in the PFS, in different subgroups with visceral disease, without visceral disease, and in bone-alone metastases. Unfortunately, overall survival was not improved. And there was no difference in terms of benefit across different ethnic groups. In Asians, the hazard ratio is a bit different from that of the overall population, but still, there was a 4-month gain in terms of median PFS, or doubling of the PFS by the combination, adding everolimus to exemestane. There were more mild side effects of this drug, specific side effects like stomatitis, pneumonitis, or interstitial lung disease, grade 1 to grade 2, in the Asian population. But then significant side effects were not reported as excessive, comparing different ethnic groups. So what about PI3K inhibitors? Well, again, 1,100 patients randomized to this trial, the BEL-2 trial. Again, AI failures, patients will be randomized to fulvestrant alone versus fulvestrant with the PI3K inhibitor called bupalisib, I think. And again, the same cohort of patients like the one recruited for Bolero-2, all had experienced failures to AI. A lot of patients having visceral metastases. Interestingly, in this study, they looked at the archival tissues and they investigated in the archival tissues for activating PI3K pathway status. And importantly, about half of those patients in-home blood samples were available, were tested for circulating tumor DNA, not tumor DNA, PI3K mutant status was assessed in the circulating tumor DNA. So it's a busy slide, but overall, the PFS was improved for the whole group, but relatively modest, just about 2 months. For those with tissue-confirmed activated PI3K, the median PFS was improved further to about 2.8 months from 4 months. And importantly, when you have circulating tumor DNA available to test for PI3CA mutant, for those having a positive mutation confirmed by the tumor DNA in the blood, the benefit was most substantial, 3.8 months gain over 3.2 months for the control group, whereas those having non-mutation in this circulating tumor DNA did not benefit from this combination. So the conclusion is, I think liquid biopsy might be important in this cohort of patients, testing for this circulating tumor DNA mutation. But again, this drug is quite toxic, so I don't have time to go through the side effects, but then we need more specific PI3K inhibitors to try to mitigate the side effects found in this trial. So lastly, we come to the CD4K6 inhibitor again. So Paloma-3, palbociclib, treated for hormone-resistant disease, having recurrence. 60% got visceral metastasis, just like outpatient, and there was a doubling, more than or slight doubling of the PFS as well, median PFS, in favor of the combination. Another one, Monarch-3, abemaciclib, just published this year. Same cohort of patients using this combination versus a single agent fulvestrant. Again, showing benefits in terms of PFS, median PFS, up to 22 months, which is reminiscent of the median PFS that can be achieved in the first-line setting if you have a good memory, right? 22 months, almost up to 2 years. We're talking about second-line setting. Benefit across different subgroups, as usual. So coming back to the real world, so what's the current cost of the CD4K6 inhibitor? I think palbociclib is the only one that's registered in Hong Kong right now, and we're talking about $27,000 per month or per cycle. And if you are looking at the PALOMA-2 data, having a median PFS of 25 months, about 2 years, you're talking a sum of more than $500,000 to treat your patient. And there's no compassionate program. Fulvestrant is currently used either as first-line therapy or as a partner of targeted therapy in the second-line therapy, but it's not inexpensive, $6,500. And I'm just quoting the price that we can get from the HA, the public hospitals. But if you use it in the private sector, I'm sure they will be escalated as well. Everolimus is slightly cheaper, right? About 10,000 cheaper per month. Still, it's substantial amounts you have to pay. And unfortunately, these 3 drugs actually are not reimbursed. So the guidelines have incorporated all these targeted therapies into the different lines of therapy, NCCN guideline, as I alluded to, ESMO ABC guideline, Hong Kong BOG guideline. What about the NICE guideline? Well, it has finished assessment or appraisal for palbociclib. So in this report, the palbociclib was appraised to see if it's really cost effective. And unfortunately, this drug, in combination with an AR, is not recommended for treating hormone receptor-positive, HER2-negative, locally advanced metastatic breast cancer, based on the fact that perhaps the baseline or the ceiling of 20,000 or to about 30,000 pounds per quality life year gained was exceeded by the assessment using the ICER, the incremental cost-effectiveness ratio. So in summary, hormone therapy is the preferred treatment for HER2-positive or HER2-negative or hormone receptor-positive or ERPR-positive metastatic breast cancer in the absence of visceral crisis. I think SERD is a drug that has been underused. It probably is most effective when used early in hormone-naive patients. And CDK4/6 inhibitor is an effective targeted therapy in both the first-line and second-line strategy for patients with metastatic disease. Even in patients with small volume visceral disease like our patient, and it has to be used in combination with AR, either AI or fulvestrant in appropriate settings. But a drug cost analysis may restrict patients' benefit. mTOR inhibitor together with non-steroidal AI, again, is an effective strategy to control metastatic disease as well after failure to AI. But I think the important thing is how to sequence all these options. When you have used CDK4/6 inhibitor upfront, are we going to use mTOR inhibitor as a second-line therapy? These are the things that we need to look at and investigate on in future clinical research. And I thank you for your attention.
Thank you, Dr. An. We'll leave the questions and answers at the end of the whole session.
Okay, great. Our next speaker is Professor Stephanie Huang. Professor Huang received her PhD in clinical pharmacy from Purdue University.